Good afternoon, good morning, good evening, everybody, wherever in the world that you may be. And yeah, wherever you are, we're super happy to have you here. We're heading into the home stretch of MMN Awareness Month, just 4 more days. And as part of MMN Awareness Month, we're super excited to bring to you today's speaker series. So it's a really good panel, in my opinion. I'm going to be moderating it. My name is Richard Sperry. I am the Chief Strategy Officer at the GBS-CIDP Foundation International. I'm also a patient living with multifocal motor neuropathy myself. And as I said, we have a great panel of patients and experts with us today. So we have patient Pam from Canada. We have Chrissie Jenkins, a social worker and board member at the foundation from the United States, and Dr. Tom Harbo, a neurologist and member of our Global Medical Advisory Board. So we get into introductions, we'll get into some great Q&A. You'll have the opportunity to ask some questions as well. Before we get to all of that, I just want to give you a brief reminder that these webinars, the speaker series, are meant to be educational, not meant to troubleshoot or consult on individual cases. So these are just informational and educational. As always, if you have any questions about your specific situation as a patient, consult your doctor. But I just wanted to get that kind of housekeeping out of the way. If you have any questions along the way, which we will certainly have time to get to, please type them into the chat in the Zoom here. So with all that being said, I do want to first just give a quick shout out and thank you to our sponsors. You see them on the slide there: Annexon, Argenx, CSL Behring, Kedrion Biopharma, Grifols, Pfizer, and Takeda. So big shout out to them for making the speaker series possible. And with that said, I wanted to give each of our panelists the opportunity to quickly introduce themselves, just say who they are, where they're from, and kind of what their role is. So Dr. Harbo, we'll start with you.
Hello and good evening, everyone. I'm excited to be here in this very nice panel. I'm the expert from the medical field, so I can talk about how MMN is diagnosed and how it's treated, things like that. I'm working from Denmark. I have long time experience with MMN.
Excellent. Thank you, Dr. Harbo. Pam, I'll turn it over to you. You're on mute, Pam. While Pam works.
There we go. There we go. I got it.
Yes. Yes.
Sorry, so I'm on the app and I'm on my phone, so I apologize because I'm actually at a patient centricity conference in London, UK right now, and it went right down to the wire. My name is Pam Snikopoulos. I am an MMN patient and was diagnosed in 2017. I live in Toronto, Canada, despite being in London right now, and I'm really excited to be here to talk more about MMN.
Awesome. Thank you, Pam, and appreciate you taking time out from the conference to join us. And
no problem.
Stoichkopoulos, right?
Yes. Like
okay.
Metropolis, right? Not that hard.
Yeah. Okay. Good. I didn't get the first time, but this time I got it. So okay, great. And last but not least, licensed clinical social worker and foundation board member, Chrissie Jenkins.
Hello, glad to be here. I'm actually based out of Murrells Inlet, South Carolina, and worked in medical social work for about over 27 years, mental health, hospice, home health, and the last 7 years in infusion care. So very passionate about helping empower patients, educate them, and enjoying my work with the board and excited about today's event.
No, thank you all. And yeah, it's a super panel. I've had the opportunity to interact and work with you all in different venues, different settings, and super excited you're here today. And again, thank you for your time. So all that said, let's kind of dive right into some questions. And we'll start with you, Dr. Harbo. When I explain my condition as an MMN patient to people, I'm always a bit challenged and kind of trying to explain how it differs from other neuromuscular disorders. So if you could, in somewhat layperson's terms, just talk to us how you describe MMN and how it differs from other neuromuscular disorders, perhaps like ALS or multiple sclerosis?
Yes, thank you for that question. So, you can characterize multifocal motor neuropathy, or MMN, which I will call it for the rest of the day, I think. But it's an ultra rare disorder, and it's less than 1 out of 100,000 people that's affected. And that's why most people don't know the disorder. It's more common in men than in female, so three male for every one female. Symptom onset is typically in the years or the age between 35 and 45, but it can be in the range from 20 years and up mostly. Then it's an acquired disorder, so there's no family history in MMN. It's like the title of the disorder, motor, so it's purely motor. And that distinguishes it from multiple sclerosis, CIDP, and many other neurological conditions that also include sensory and sometimes cognitive impairments as well. And then it's important that MMN is a treatable disorder. And compared to ALS, it has a relatively favorable prognosis. ALS is devastating disease that causes the death from the patients. But MMN can be treated, and MMN patients have a normal expected lifetime. So I think MMN is mainly misdiagnosed because it's so rare and it is mistakenly thought to be other and more common neurological disorders.
No, thank you for that. And that's super helpful, and I love that kind of that simple overview. I myself faced those diagnostic challenges. I was misdiagnosed with ALS before I finally got the diagnosis of MMN. But I'd love to hear from our patient here on the panel and Pam. And Pam, talk us through what were some of the biggest challenges you faced throughout the diagnosis process, and what did that look like for you?
Yeah, so I was actually talking about it at this patient centricity conference. So,
Hmm.
so apparently the average I heard was 6 years to diagnosis, and being above average, I was 7. It started with a twitchy finger, that I noticed just kind of like a little shaky when I was typing on my computer. And then moved to, I had my son I was a geriatric mom at 41. So I was 40, I was pregnant, and I started to limp. And so didn't put those two things together. I was misdiagnosed initially with the finger issue with a trapped nerve. And then started to limp in like 2011 when I was pregnant with my son. It's several, like, long story short, many visits to a neurologist who couldn't find anything, then many visits to an osteopath, acupuncture, what have you. And it was actually a podiatrist that because I went to get insoles, and I said, "Oh, look at my leg. It's quite a bit thinner than my other leg." And he's like, "That's neurological. You need to go back to your doctor." So another 2 neurologists later, I finally got to the third neurologist, who then actually started to do testing on the anti-GM1 antibody. And at that point, I had sort of made the connection between the hand and the foot. And so then I think at the same time that the neurologist had found it, I had found MMN, and I had actually seen Brenda Peralez's video. And it was like a total aha moment, because I had essentially, she talks about like her ankle like folding over and like her just falling. And I had like almost the identical thing happen to me.
Hmm.
And so, but I still had to advocate for IVIG treatment, because I didn't have the anti-GM1 antibody. And so I think in some of the meetings that we've had, not everybody has that. And so it was sort of dismissed. But then when I said, okay, tell me why it's like, I went back to the neurologist who had tested me and I said, tell me why you don't think it's MMN. He's like, okay, we're going to try you on IVIG. And that was in 2017. And I had IVIG and then I got violently ill on the loading dose. But within 3 days, I started to see, like, my fingers had started to curl up and I saw them uncurling. My toes had started to curl up and I saw them uncurling. And so I knew that something was up, like something was actually working when a person who knew I was like struggling, we thought it was like a back issue, we didn't really know, said, oh my God, your walking is so much better. What happened? And that's when I knew, okay, actually, this is not placebo. This is real.
Yeah.
I am actually having a response to treatment. And so that's like, I mean, the diagnosis really came with the treatment response.
Yeah. And I'm smiling because I love hearing patient stories about when they first realized that they were responding to IVIG. And in many cases, that kind of differentiates from a diagnosis of ALS. So, yeah, I love hearing those stories. And by the way, Pam, you described yourself as a geriatric mom. Given your energy level and everything that you're doing for the patient community in Canada, like geriatric is like the last.
Listen, I'm almost at Freedom 55. So
Okay.
Get close.
But no, you're doing great stuff and keep it up. No, and we can laugh and kind of make light of some of these things now, and kind of joke around with patients sometimes, like, oh well, how many neurologists did you see before you got diagnosed with MMN, and kind of have a contest to see who has the highest number, and it is taxing. It is very, for me at least personally, it was very emotionally taxing, emotionally draining, and Chrissie, I guess I'll turn to you and in your observation, and I realize this is a broad question, but what are some of the biggest emotional and social challenges that MMN patients face pre-diagnosis and post-diagnosis?
Exactly. Well, and I've been fortunate enough to carry the stories of thousands of patients throughout the years, and that's a special honor to walk, alongside patients and to see their worldview and their struggles, and as a social worker to commit to how can I improve, their life. I think the first one, I call it coming to terms with the new normal, and I think that's initially and even ongoing. It's a stage that has to be revisited in terms of adjustment and acceptance of the diagnosis and the prognosis. And I think, that happens in different stages and different, speeds and for different patients, but certainly the altered quality of life, how they perceived how their life has changed, what it used to be compared to what, remains now for my new normal. I kind of look at what the dynamic is, that helpless, hopeless, thought or loop that patients get into. And then we try to hope to accomplish the, empowered and encouraged. We kind of try to graduate to that, but certainly anxiety, depression, everything you would expect to see when someone's life has, in the words of my patients, I've been hijacked, or I feel like I'm, being held hostage by this illness. There's certainly the coping strategies that come along with acclimating to a significant life-altering disease and navigating that through, their family, their school, their life, their church, the healthcare system in general.
Yeah, and I do want to stick with you just for a minute, Chrissie, and I love that kind of helpless, hopeless to empowered and encouraged. I think that's a great way to think about how to kind of shift a patient's mindset. And what advice do you have for patients who are struggling to do that? Because I found myself as a patient just managing the IVIG treatments themselves is a lot, just in terms of the time, and then you're trying to manage your job and your family on top of all that, and it just becomes a lot. And do you have any advice for folks on kind of how they juggle all those balls and take care of themselves emotionally?
Yes. Be gentle with yourself first and foremost, and that's going to look differently from one day to the next. Some days you're going to have more capacity to do that, and other days you're going to have very little capacity to do that, to allow yourself to be where you are in that moment, but also being conscious that our mental health is very important. It's very interconnected to the physical. And so to always be mindful of what can I do when I feel myself struggling more. And that may be reaching out to a community of support, that may be securing some counseling support, reaching out to the foundation for people who have experienced these same exact issues to stay connected and to help process aloud, talk about those things, journal them, do anything that you can to help manage that stress. A lot of people like to be stoic and to, just to keep soldiering on. That is okay to be strong and stoic, but also to balance that out with allowing yourself to feel, all the stages of grief and loss and how the stress may be impacting your life. You can't do it all at one time. It would be impossible. So to take advantage of any and all support systems, do not be afraid to do that or ashamed.
Yeah, I think those are great points, and while stoicism and strength are great, I think they only get you so far. I was 46 years old when I was diagnosed with MMN. I'd never talked to a mental health care professional in my life. About 6 or 8 months post-diagnosis, I started seeing a therapist on a weekly basis, and it made all the difference in the world for me. So I think, to your point, using those resources and using the kind of the safety net you have around you is critically important.
Right.
And just shifting gears back to the physical piece and back to you, Dr. Harbo. And I do want to give Dr. Harbo a shout out before I ask this question. And it kind of takes me back to the symposium that the foundation had outside of Washington, D.C. in the fall of 2023. And Dr. Harbo was leading or moderating an MMN breakout, and he had his PowerPoint slides up and was prepared to give a really nice presentation. And the MMN patients, we just kind of ganged up on him, and we started peppering him with questions and this and that. And I think he got through one slide before it was completely off the rails. But he was a great sport, and we really enjoyed our time with you, Dr. Harbo, and hopefully we can do that again in Denver this fall. But back to the physical piece, I would like you for a minute just to talk to us about kind of current treatment standards. We've talked about IVIG briefly, but talk a little bit more about that. And then do you see anything new promising coming on the horizon in terms of new potential therapies?
Yeah, thank you for reminding me about that seminar in DC. So it was a lovely crowd, I have to say. I was working that day. So yeah, but yeah, back to treatment in MMN, because we are happy that we have treatment for patients with MMN, but it's still pretty limited because we have immunoglobulins, and that's basically it. Then you can give immunoglobulins intravenously, or you can do it subcutaneously. Some places it's more available to have it intravenously. Some places you can have both. Some patients prefer one, and some patients prefer the other. So most patients start with intravenous immunoglobulin, and if they respond fairly well to that, they can continue with maintenance treatments, either with the intravenous or the subcutaneous. Then we know that some drugs that are effective in many similar disorders like CIDP, corticosteroids, for instance, is not effective. It might even worsen symptoms in MMN. Also, plasma exchange seems to have no benefit in MMN. So we are pretty much stuck with the immunoglobulins, and it works fairly well. But my experience with my patient is that even though they are on maintenance treatment with immunoglobulins, they tend to deteriorate very, very slowly over the years. So I'm afraid that immunoglobulins don't stop the disease completely. So it would be nice if we had some options. Also, for patient who doesn't tolerate the treatment, we don't have treatment options. But there are some trials ongoing right now in MMN, and that's very nice because it has been an overseen disorder for many years. But there are clinical trials running right now. We have trials running in Denmark. We have them running in United States and Europe. I think most of the world. So we don't have treatments to prescribe yet, but I think it would be pretty manageable to get involved in such clinical trial at the moment. And the target that the companies are going for now is anti-complement treatment. And complement is a protein that you have in your blood. It's part of the immune system. It clears up bacteria. And it also seems to kind of damage the nerves or be involved in that damage to the nerves. So by blocking that, it seems that we can stop the when you have these white blood cells going to attack the nerve cells, you can stop that by blocking the complement, and also complement have a direct damaging effect on the nerve cells. So I think that seems to be promising for the moment.
That is exciting, and I also know there's some exciting dosing and administration options being looked at with those complement inhibitors that would be perhaps less invasive than the IVIG infusions. So that's exciting as well. From your perspective, Dr. Harbo, for this new class of drugs, the complement inhibitors, what is the side effect profile of these compounds, and are there any concerns that patients should be on the lookout for?
Yeah, of course. You never find a treatment without also having some side effects. And it is a drug that is modulating the immune system. And we know that complement is very important for clearing bacteria. And therefore, we have a concern that you can get bacterial infections when you block the complement system. So therefore, before you can start the treatment or go into the trials, you have to get a vaccination for some kind of bacteria. For instance, meningococcal bacteria. That's a very severe disease that you should be aware of. Also, bacteria that can cause pneumonia is it recommended to be vaccinated against. But again, the new drug in the pipeline don't block all complements. So it's only, you can activate the complement system by 3 different ways. And these compounds will only block the antibody mediated activation, and that seems reasonable because many MMN patients have these antibodies against ganglioside GM1. So by doing that, you still have some of your complement system active.
I see. So sounds like some excitement and could be meaningful for patients if these drugs make it to market, but a lot more to come. So thank you for that, Dr. Harbo. And I did want to kind of bring us back into the present day and thinking again about current treatments, current therapies. And Pam, great, that's perfect timing. You're right back on camera. Yeah, I did want you to talk to us a little bit about what treatment looks like for you and how well you tolerate the infusions, and kind of what pointers from your perspective you might have for other patients in terms of how you prepare and how you deal with the infusions, and kind of what follow-up looks like for you.
Yeah, sorry, I just was like in a quiet space that became a noisy space, so just moving around here. So I am one of those interesting individuals who's actually done. So I started with IVIG just before COVID. Then tried subcutaneous, and for me, it didn't quite have the same effect. So then I went back to IVIG.
Mm-hmm.
And I'm hopefully there's not too much. There's still a bit of noise here, so I'm hopefully you can still hear me.
Yep.
So for me, like hydration is definitely key. So I really try to hydrate. I use something called Hydrolyte, which is like a electrolyte kind of drink. I drink, like they know me at the clinic. They're like, oh, she drinks. Yeah, you drink so much water. You're good. And for me, um, the as I said, the first dose was really quite the loading dose was like I was very nauseous, mostly because of the pain. I had such a bad headache.
Mm-hmm.
And so that led me to reduce the rate of because I talked to my doctor about it, and he said you try to reduce the rate of infusion. So for a very long time, I was only doing like in Ontario. So it's actually different in Canada, province by province. Some people go really fast. In Ontario, the standard is about 200 mils per hour as the top rate of infusion.
Oh, wow.
I don't go, so for a very long time I didn't go past 150 mils per hour, and now I go 200 mils per hour. So
Mm-hmm.
I go 180. So for me is sort of my top speed. And it's funny because even when I switched, that little difference, I could feel it in my head. I felt a little bit lightheaded. So that prevents me, I feel a little bit tired, but it prevents me from getting a headache. Now, I have talked to other people who say it doesn't matter what I do. It doesn't matter if I infuse at like 100 mils, I still get the headache.
Uh-huh.
I'm fortunate in that I just feel a little bit lethargic for like a day. And I set up shop at the clinic for me. So I know some people have it at home. For me, why I think subcutaneous, aside from it, like it wasn't as effective, it also, for me, was just about I had young kids, and so it was always the feeling like this was the chore, and I was doing it at like midnight and stuff. It just wasn't fitting into my life. Whereas
Sure.
when I go to my hospital clinic, it's like a little bit of a spa treatment. So not hard to say that like getting a needle is a spa treatment, but it feels a little bit calmer. So I think it's really about what works for you. I know lots of people who love subcutaneous and think it's the best thing because they can travel and they're more stable and they have less side effects. For me, I don't have such side effects on IVIG, but for me, I think it just works for me to like it also for me it was a reminder that I was sick.
Yeah.
And so for me to go in 2 days every 3 weeks which is now my treatment schedule, it just is like I'm in there, I know I got my schedule down, and then I'm done and I just get on with my life and I
Mm-hmm.
kind of forget about it. But I think for some people they love the flexibility, and I get that. It just for me it didn't quite work.
Yep. Yeah, I know I've tried sub-Q myself. I'm back on IV. I've done IV in a small infusion suite. I've done it at a big hospital center. I'm doing it at home now. It's great that there's options, and those options are certainly going to differ from country to country, market to market. But I think options for patients are always good. And Pam, when you talked about hydrating and drinking water, I heard my wife's voice in the background because she's always politely nagging me the day before my infusions, drink your water, drink your water. And,
Yeah, yeah,
kind of an unofficial mantra of the foundation is no one walks this journey alone. And Chrissy, I'd like to turn to
true.
you and maybe even broader than MMN. I'd like you to talk about just kind of the role of care partners in helping patients with our conditions and kind of what good looks like to you in terms of a partnership between a patient and their care partner.
Right. And I think that is very truly important, that you trust and you have a good rapport with whoever your infusion center is, your neurologist, whoever. You have to, and I tell people that in my support groups, if you don't feel comfortable, you don't feel heard, seen, understood, or if you're being dismissed or you're not able to voice your thoughts and feelings well, you need to look for another doctor or make sure that you feel confident in the team that you have surrounding you, because that's truly, your team has a lot to do with your satisfaction with care and your outcomes. So certainly, there are centers of excellence that that we have on our website for GBS-CIDP, and a lot of those can give you good resources to reach out to options. But also, I think to have good lines of communication, to be able to come in maybe equipped with questions if you're having issues or concerns, that you're not fearful to discuss those, that that you don't think that they'll be dismissed, that you can trust that you're being heard. And then when you go into the infusion center, that you feel like you're having, I like the idea of what you said, a spa day, because some of our patients say that, like you've got the Wi-Fi, the warm blankets, the snacks, the the shows. I think it should be the comforts of home to normalize it as much as you can. So, some of them say we see you more than we do some of our only family members. And, I think it becomes a special relationship, so that you trust that they're doing the best by you, and that you can speak up and ask questions when you're empowered, or you feel like something needs to be done differently, for us to be able to reach out to your provider and advocate for that change. So there are a lot of opportunities, and I don't want to miss the caregivers in here. I really feel like the caregivers, when you mentioned your wife, Richard, I think the caregivers are unsung heroes. The hydration stuff, the wellness, and caregivers need to make sure they're taking care of themselves. We talk a lot about that self-care when in the clinic setting. I meet with families and patients, and we actually do some support groups from time to time for caregivers too, just to make sure that they're getting what they need to support the patients. But open, honest, vulnerable communication between patients and care providers is not just a luxury. It's a necessity, and healthcare, fast-paced, so much distrust, so much, concern. You really need to feel like you can have those hard conversations. But yeah, it's a process, and don't give up on that. I hear a lot of horror stories, but also I hear a lot of wonderful stories after years and years of misdiagnosis, that they have found the right place, the right people, and have built their team. So that's pretty remarkable.
Yeah. I feel like you hit home on so many of those points, Chrissie. And I think one is just finding the right members of your care team. And I know Dr. Harbo's here, and obviously the neurologist is kind of at the center of that care team, but there's so many other supporting members. And in my case, it was kind of like you said,
Oh,
where
the nurses are at the core of your care.
that's where I was going. The nurses who I saw every 3 weeks, and they knew me like better than anybody, and they knew like how I would respond to certain infusion rates, and they would be keeping an eye on my hydration as well, and they would be ask me if I was like traveling for work, and kind of link that back to how I was feeling or how I might be responding. And yeah, I think finding whoever that person might be, it could be a physical therapist, could be an occupational therapist, but finding that person who can provide you support. And then you hit it a few minutes ago, and right now, Chrissie, just that importance of self-care, and both patients taking care of themselves and caregivers taking care of themselves. And Pam, I know you mentioned that you like to go do your infusions and kind of forget about the disease for a few weeks before you go back in, but the disease never goes away, and the caregiving responsibilities never go away either. And it's a lot, and just finding those right appropriate care partners, finding that right self-care, I think is critically important. So thank you, Chrissie. I do want to turn it back to Dr. Harbo for a couple of questions here. And Dr. Harbo, one of them came in through the chat here, and it is back to the treatment question. Is there any evidence or science behind rituximab as a treatment for MMN?
I haven't seen any studies about rituximab in MMN. So I know that when you have the back against the wall and you don't respond good enough to immunoglobulins, you have a tendency to try what works in other cases. So, so if I have a patient that really does respond poorly to immunoglobulins and continues to deteriorate, then I would probably try rituximab as well. But I don't have any good case to tell that this works very well. But I think there's an overlap between MMN and motor forms of CIDP that, yeah, and I have to say that rituximab is not a magic treatment for CIDP either, but again, a drug that we use in tough cases. And rituximab is not that toxic like other severe immunosuppressive drugs. Another drug that early in MMN was used is cyclophosphamide, and that is probably effective for such patients, but it is very toxic, and it is an old-fashioned chemotherapy. So that should be restricted to patients with severe disabilities that doesn't respond to treatment. But I wouldn't say it's a mistake to try rituximab, but we just don't have any hard evidence to kind of support that.
Very fair, very fair, and thank you for that. And I'd like to stay with you, Dr. Harbo, and kind of go back to something you said in an answer a few minutes ago, and you used the word deterioration. And to me, that kind of underscored the fact that MMN is a progressive disease. And one way for me, at least in my simple mind, of measuring the progress or measuring how a disease is progressing would be if there was a biomarker that we could point to. And I know that's frustrating for me when I go to talk to my neurologist and he's asking me how I'm doing, and most of my responses are very qualitative or descriptive in nature, and I can't point to any hard data points in terms of how I'm responding to treatment, how I'm holding up in between infusions, et cetera, et cetera. And I'd like to ask you how far away do you think we are from ever having a biomarker for MMN? And if we do have one, what could that potentially be?
I have to say that I'm not that optimistic about a simple biomarker for MMN. So we are still dependent on what the patient reports and your own clinical examination. We can do some objective measures with grip strength, but that's not very good when it's the finger stretching weakness that you have. So yeah, symptoms and objective neurological signs is what we have now. We have some good tests for diagnosis, which is the ganglioside antibodies and, more important, the electrophysiological examination. But it has been tried to use for surveillance of treatment efficacy, but it's not worth it. Then we have the neurofilament light, but you have to have very active disease to have it elevated in MMN. So that's not sensitive enough. There are work on more peripheral nerve damage factors, but I think it's a few years on the way, and I'm not sure it's a perfect biomarker for MMN. So I'm not that optimistic. So I hope that we can get more effective treatment that can stop the treatment so that we can see it on the patient, and the patient can report that, yeah, this actually works, and now I'm stable. I haven't deteriorated for years.
Yep. No, that's perhaps not the answer that the community wants to hear, but we appreciate the honesty, and yeah, it just underscores, to your point, the importance of good treatments. And it's great that there's some things under investigation. So kind of follow-up question to that, in the absence of a good biomarker, and you brought up grip strength and some of the limitations of measuring that, but are there other objective measures that, as a clinician, it would be helpful for patients to kind of track and monitor over time and come to you at an appointment with data to show how they might be doing?
Um, yeah, MMN is different in any patient because you can have different nerves affected between patients. So it's not that you can take one test and use for all your patients.
Mm-hmm.
And a neurologist will do a muscle test manually. That's how we do it. If you have weak grip strength, you can actually measure the grip strength at home. So that would be valuable. But if that's not the muscle that's affected, then
Yeah.
then you can discuss with your patient what is affected when you get worse, and can you try to track that? And that could be your handwriting, that can be cramping when you walk, that can be your foot starting to dropping when you have walked 10 meters instead of 50 meters. So you have to kind of find individual things to look at for each patient.
Yeah. Okay. Thank you. And kind of like to shift gears a little and maybe ask one question that I'd like to ask all three of you to touch upon. And if you were to sit down and meet with a newly diagnosed MMN patient, what would be the advice that you would have for that individual? And we can start with you, Pam.
So, I mean, it's just so interesting. So, because I'm at this patient centricity conference and I met some other people who were patients, and one of them had been diagnosed with MS. And we both talked about the fact that here we are, like with this progressive disease. But the reality is, none of us know what's going to happen. So that, I mean, I think the uncertainty, the dark cloud, like hangs over you. I knock wood all the time. I have been stable since getting IVIG. I haven't declined. And I know that that's possible. I've met people, like I just, we did the CN Tower light up a couple of days ago. So I got to meet people who have had that decline. So I think, you know, for me, my takeaway, so one of the things, diagnosis to me, I think there was a question like we talked about in the pre thing. Diagnosis to me was relief. It was like, I'm not
Yeah.
crazy. I get that, like, okay, now I know what I have. And here's a treatment that is working for me. I'm lucky in that way. So I'm lucky, unlucky, I always say. But I think it's about, doing what you can. So even recently, a couple of days ago, somebody was talking about how they love running. And I used to be a runner, and I miss the clear head of running. But
Mm-hmm.
it's like finding that thing that you can still do that you enjoy. And if it's not, for me, I'm still able, I was talking to somebody, like I'm still able to ride a bicycle. So for me, I'm lucky I can bike instead of run, although I can't do it in Toronto in February, but I can do it. I think it's just recognizing that none of us really know what's going to happen. So like you can live with that dark cloud over you can be the Charlie Brown with the dark cloud over your head, or you can just look at what you can do now and take advantage of what you can do now while you can do it and like capitalize on that. I also think honestly, I find some, I do a lot of volunteering, I do support group, I do that stuff. I find a lot of satisfaction in that. It gives me like some purpose. So figuring out whatever it is, it doesn't have to be it doesn't have to be volunteering for MMN. It could be something else, but it's like figuring out what that gives you that joy and that purpose, and that makes you maybe like just grateful for where you are today. And that to me is like, I don't want to sound like a gratitude book or whatever, like, because I think some people really struggle, and I did struggle at some point with, who am I? What's my identity? And every time, I'd get really overzealous, and I'm going to do all this stuff in the city. And then I realized, oh my God, I'm too tired today. I can't do it. But I think it's like, it's figuring out what you can do and capitalizing on that while you can do it, and being grateful for that time, and you can feel sorry for yourself. You can be in that negative space, but don't try your best not to stay in that space. And whether that means counseling, whether that means getting outside support, whether it means just going to a support group meeting, just not staying in that negative headspace, I think, is really important. Because for your own, mental state, but also for your physical state, because it does impact your physical state.
Absolutely. And yeah, and you don't sound like a gratitude book at all, Pam. I mean, it's real life. It's what's worked for you. I personally find it really inspirational when I look at you and just your energy and how you found alternatives to running, and find things that give you purpose and give you
I take a
meaning.
lot of naps. That's where I get the energy from.
Napping's great. Napping's great. So Chrissie, I'd love to hear your perspective on if, again, in your case, not just MMN, but CIDP, someone recovering from GBS, what advice would you have for them?
Right. I think the only guarantee in life is that everything changes, and this illness will test you in more ways than you ever thought possible, but you will come out stronger somehow, some way. You may not know right now, but with a renewed sense of meaning and purpose, and that is different for every single person. And just the stories of endurance and perseverance and resilience will be a special gift that you will arrive at one day. And that'll be the gift that you give to other people as well that are kind of come along. That's why I love my support groups. The new patients and the veteran patients are just amazing at how they support each other. But to be comfortable with the unknown, our human nature is to want to understand and how to anticipate and know where I'm going to be, how many steps I can walk, and and am I going to be like he is or she is, to be comfortable with where you are right now, and to learn to accept and understand that everyone's journey is unique. This is an illness that is unpredictable, and I think that's hard for us to wrap our heads around. It's hard for us to wrap our minds around, especially when our life is so significantly changed. So to continue to get up every morning and try again.
Yep. No, I think that's spot on. And it's funny, both Chrissie, you and Pam, in different words, brought up the concept of uncertainty and just dealing with that. And and I feel that every day. And I think, to your responses before we get to Dr. Harbo, I would add just build your team. And we talked about that a little throughout the past 45 minutes, is just find that team that's supporting you, family, healthcare providers, friends, other patients, et cetera. And I lived with MMN for 2 years before I met another MMN patient. And that I really wish that had been 2 months instead of 2 years, and just meeting Clive, and then and kind of the foundation opening up doors to me to the broader MMN community made all the difference in the world for me. So I would just that team concept of helping you get through this, I think, is critically important. And turning to you, Dr. Harbo, what do your conversations look like in your clinic with newly diagnosed patients, and what do you try to tell them?
Yeah, that's actually the most difficult questions for me as a physician to have. But I'm inspired about what Pam and Chrissie is talking about. And I think it's important to accept that this is a chronic disorder and look at the possibilities instead of the limitations. And there are, even though you have disabilities, there are things that you can do, and you can have a lot of accessibilities also to help you doing your daily activities. But for a medical perspective, I think it's important that you find a team also on the hospital that that you trust when you are treated. You trust that you get the correct treatment, that you get the correct information, that you understand your options. It's not important if you choose to have intravenous or subcutaneous immunoglobulin. It's what feels the best for you, and you should have support even either treatment you choose. And then you should have good access to the nurses at the clinic and also the doctors. So if you go into a period where you are getting weaker, then it's important that it's looked at, and you get into an appointment to see if you should change your medication. So that's what I talk to my patients about, how they choose the correct treatment together with the physician, and how they get support when they have problems with the treatment or deterioration with their treatments.
Mm-hmm.
And then I also always refer the patient to a physical or occupational therapist, so that they can get help with exercise, and if they need a brace, things like that. So that's important too for the patient.
Yeah. Yeah, it's funny. I hear you saying emphasizing a team-based approach to care just from a kind of a hospital or a physical health perspective. But again, I think just the importance of getting a team around you to provide you with the right resources and care. So I see Pam's raised her hand with another response, another corollary here.
Thanks. I just wanted to say, because this actually came up in a support group meeting, and so there is quite a variance in terms of how frequent people are getting IVIG, and it's quite different for everybody. And maybe this is a question to Dr. Harbo in terms of, is there like a standard? Because from the conversations that I've had, it seems like IVIG every 3 weeks seems to be 3 to 4 weeks seems to be the standard. And I know that can vary, but I'm like, I think so. One comment, and then the question to Dr. Harbo: is there a standard? And the comment that I would have is, make sure if you notice the drop off, make sure you're recording it, like when it's happening, so that you can have a conversation with your doctor about it. Because I've heard of people like having it for 6 weeks, like every 6 weeks, and that's just like, in my knowledge of IVIG, that is not appropriate. So having that conversation, if you're dropping off, definitely record that. But I just wanted to ask Dr. Harbo, like, is there a typical, like, kind of, how long does IVIG last in your system? That would be my question.
Yeah, that's
Sorry,
a good question. And it is very individualized in MMN. So you can probably only measure the immunoglobulins in your body for maybe 3 weeks, but it can still have some effect, even though that you can't measure it in your blood. I think we used to do treatment like we gave 1 full dose of immunoglobulin. That means 2 grams per kilograms over 45 days. And we looked at the response, and then we told the patient, okay, if you get weaker again, call us, then we'll start over. And some patients actually could go for a very, very long time before they started deteriorating. Some had it after 2 or 3 weeks, some had it after 6 weeks, some had it after 6 months. And MMN in many patients are very, very slowly progressive. So when things are progressing very slow, then you tend to not notice it. So when my experience now with MMN is that 6 months is too long, but but I tend to get the interval shorter and shorter. And you probably know already that many of my patients are on subcutaneous treatment, so they will get it every week. But most patients that we treat on IVIG have the treatment every 3 to 5 weeks. So I think that would be the standard, but it is very individualized. And some patients, if they are not that severely affected by the MMN, they don't like to go to the hospital all the time. So you have to balance that also.
Thank you, Dr. Harbo. And your mention of subcutaneous treatment is a good segue to a question that came in the chat here, somewhat specific regarding products. But in your experience, have you seen any difference in efficacy between Hizentra and HyQvia? And I'm not even sure both of those are on the market in Denmark, but they are here in the US. So I was just curious if you had any perspective there on those two different subcutaneous products.
Yeah, I think from a legal perspective in Denmark, these two products are considered to be equal, but it is different treatments because Hizentra is only immunoglobulins, whereas HyQvia is a combination of hyaluronidase that facilitates the immunoglobulins to run into the subcutaneous tissue. So you can actually give larger doses and give them faster with the HyQvia. So kind of effect and side effects wise, it looks a little bit more like giving it intravenously. But you always see patients that seems to respond better on one product than the other. But if I take 10 patients giving one treatment and 10 patients giving the other treatment, then I can say that the one is better than the other. But if you have trouble with one of the treatments, you can try to shift and see if it works better for you.
Got it. Thank you for that. And I'm looking at the clock here. We only have about a minute left. So first, I want to give a huge thank you to Chrissie, Dr. Harbo, and Pam, three people who I respect and appreciate enormously. So I appreciate you all making time today. I know it's late in the day for Dr. Harbo and for Pam. Pam's busy at a conference, and it's just great to have you guys on this panel. And I also want to give a big shout out to the audience. I don't see you guys out there. I don't know how many are on here. I'm assuming it's my MMN tribe. Really hoping to see you all at the symposium in Denver in September. As I mentioned 2 years ago, meeting all you at the symposium in DC was a really meaningful experience. I think it's there's strength in numbers, so let's get out there. Let's see each other in Denver. And again, a big thanks to our sponsors here. You see the logos there. Again, they make this possible. I will put a plug into individual donations from patients, from supporters of the foundation, make our programming possible. So please consider a donation if you have that capability. And then again, that disclaimer, hope you learned a lot here today and this was informative. If you have any specific questions, though, about your individualized treatment and care, talk that over with your physician. So with that, I want to thank everybody for their time today. Thanks again to the panelists, and have a great day.